I want to get to the topic of the afternoon, and thank you all for coming on, which is sciatica, something that we see very often in neurology practice, both in the inpatient in the hospital and also in the clinic in the outpatient setting. Without much further ado, I'll get going. So there's just an outline of what we're going to be talking about this afternoon. We'll start off by talking about some of the anatomy of the nervous system and the spinal cord, just to get us all situated kind of with what region of the body we're talking about. And then we'll dig into kind of the meat and potatoes of the afternoon, which is sciatica. And my main goal is to answer a couple key questions, how it is that sciatica develops, what it is, how we exactly kind of characterize it. As a clinician, how I diagnose it, how I'm thinking about working up a patient when I see symptoms that might suggest sciatica, and then treatment. And I'll get into some of the studies that are out there for some different modalities that we often recommend in clinical practice. I'll talk a little bit about mimics, or things that present very similar to sciatica, but are slightly different, and how those require different types of treatment, different types of recommendations. And then I'll give you a few tools, some worrying signs that you should be kind of on the lookout for if you have symptoms that might sound like sciatica, and when you should think about seeing either your doctor more urgently or presenting to an urgent care or emergency room. And obviously, I want to do my best to equip everyone with tools to prevent sciatica, and a lot of it actually you guys got a good intro to with the warm-up exercise. So let's start by talking about the anatomy of the spinal cord. So the brain and the spine make up the central nervous system, and the brain is obviously surrounded by the skull, and the spinal cord is basically the extension of the brain going into the rest of the body, and the spinal cord will then send out nerves that will go to important organs, muscles, and different parts of the body that help kind of maintain the balance and function, and allow us to do the things that we all do. Around the spinal cord is the bones of the spine, and we can divide these into three sections: the cervical spine, which is kind of most likely thought of as like the neck region, the thoracic spine, which is kind of the mid back kind of region, upper and mid back, the lumbar spine, which is the lower back, and that will be the focus when we're talking about sciatica, and then the sacral and coccyx areas around kind of the hip bone and pelvic regions. What I will note is that the cervical spine has to support the brain and the skull, which can weigh up to about 10 pounds when taken all together. And that puts a lot of strain on the cervical spine. And as you can kind of see from this picture, the bones, these bony parts in the front, are actually smaller in the cervical spine than they are in the lumbar thoracic spine. And so having to carry the significant weight from the brain and the skull, and also having maybe a little bit less support, the cervical spine becomes an area of frequent degeneration. And somewhat similarly, the lumbar spine kind of has to support the weight of the entire body. Even though it has some bigger bones to do that, it is subject to, over time, degeneration. And that can lead to arthritis, and can predispose to things like sciatica. So keep that in mind as we go through. That's a pretty important part of the development. So when we're talking about sciatica, we're really talking about the lumbar spine, the lower part of the spinal cord. And so this part of the spine has particular features to it. There are these bony parts here, the vertebral bodies, and in between the vertebral bodies is these discs, which are kind of like cartilage, kind of a squishy, flexible yet sturdy is the best way to describe it, material that goes in between the bones, and it allows for rotation, extension, flexion of these bony parts to allow us to bend over and pick something up, or to stretch, and all these kinds of things. And there are, like I mentioned, kind of 5 vertebral bodies, the discs in between them, and the spinal cord exits through these processes, these little holes at the side, probably best appreciated in this diagram. And so this is the spinal cord in the middle, and these small nerves leave through the side uh, of the actual bony part of the spine, and that goes to muscle, it goes to other organs. Um, and this is kind of how the organization of the lumbar spine, the thoracic spine, the cervical spine, all throughout the body is done. And then, as I mentioned, the disc portion, this is seen right here. And there's, like I mentioned, it's sturdy but flexible, and part of this outer part is meant to be fairly sturdy, and then this inner part here is it's a little more squishy to kind of absorb the impact from various things, whether it's jumping when you're playing basketball, or the impact from running a mile or two when you exercise. And so sciatica is a condition that involves the sciatic nerve. And this is just a diagram to kind of highlight where exactly we're talking about, which nerves, which roots are we talking about when we talk about sciatica. And so this is a picture of the spine like I showed you before. And notably down here, we're looking at this L4, L5 region that has these nerve roots that then extend, and those will come together with the nerve roots from lower down in the spinal cord and form the sciatic nerve. And so this is how this large bundle, this large nerve, the sciatic nerve, comes from the joining of these multiple nerve roots as they exit the spine. So now let's talk about how exactly sciatica kind of comes about. And this is one, perhaps the most common way that sciatica develops, but not the only way. And so as I mentioned, kind of over time, as you're, running like I was in high school and college, or, you're playing a lot of basketball, kind of absorbing the impact of, movements, or, doing what a lot of us are probably doing right now, which is, sitting down in front of a computer and, not being as mobile. Over time, kind of all of those, mini little insults can lead to degeneration of that disc area, that kind of flexible but firm part of the spine. And as that happens, you get a little bit of inflammation that can occur in that area, notably denoted here. And that inflammation can cause what are called bone spurs, which are kind of, this is where the actual bone of the spine will get these small little kind of protrusions that can, degenerate and kind of impact the disc in between. And the disc itself can also degenerate over time from impact, also can be, if from tobacco use as well, has been shown to decrease the integrity of the disc. And over time, this kind of middle kind of part, this squishy part, can protrude into the region where the nerve leaves the spinal cord. And that protrusion can cause irritation, it can cause inflammation, it can cause damage to the nerve. And if it occurs in the right position in that, L4, L3, L5 region, you can get pain that goes down from the back into the back part of the leg, and that causes sciatica. So just some little details about sciatica, just so we can all be on the same page. As I mentioned, this is usually in that L3, which is the part of the lumbar spine, even to S3. And it's called a radiculopathy because it involves the root of the nerve. Radical has a Latin root for root, and is that nerve root that is inflamed, that is irritated, and that's what causes the symptoms of sciatica. The prevalence is actually quite high. It's anywhere from 10 to 4% of the population. The most common ages for this to develop are in the 30 to 50s, but certainly folks can develop sciatica at older ages or at younger ages. It's usually one side, it's usually unilateral in nature, but it can be bilateral as well. And kind of as I mentioned, this is characteristically back pain that kind of radiates into the butt region and goes down the back or the posterior lateral aspect of the leg and goes down to the foot as well. It usually goes past the knee, but there are some cases where folks have pain that just stays at the knee, but usually goes beyond the knee down to the leg and foot. The most common causes are kind of, as I mentioned, that disc protrusion or disc herniation that can occur, where that squishy part of the disc kind of pushes into the region where the nerve exits the spinal cord. Also, kind of along with that, arthritis of the lumbar spine area can lead to some protrusion of that disc, or it can lead to some loss of the integrity of the bones around that area, that can lead to sciatica. Stenosis of the spinal cord, if that region doesn't have as much area and is slowly getting kind of pinched down, that can lead to a sciatica as well. And obviously trauma to that area, whether it's motor vehicle accident or some other types of accidents, can cause sciatica as well. There are some rarer things that can happen. This is more just to have this on your radar, but tumors rarely impact this region, but it is possible. And I've seen inflammatory kind of conditions that have a predilection for the nerves in that lumbar spine kind of region. And then atypical infections. These are kind of things that would need to be seen by, obviously need to consult your neurologist or even a primary care doctor to, if there's suspicion for some of these rare causes. But most of the time, we're talking about arthritis, herniation, spinal stenosis as the main causes. And so if I'm seeing someone in the clinic, they come to my office and they're telling me, basically the symptoms as I described it to you, they're having some pain that goes down, from their lower back down the back of their leg into the foot. I have maybe a higher suspicion for something like sciatica as the cause. And so a lot of the diagnosis is done just by hearing the history, as we call it in medicine, or even the history of present illness, or the HPI. If someone comes in with those symptoms, I'll obviously want to ask, a lot of other parts of their history, past medical history, any exposures, any recent trauma, things along those lines. But a lot of it can be done just by talking to the patient. The other part is a physical exam. As neurologists, we do a very detailed examination of the entire nervous system, and that can give us a lot of clues as to where specifically within the lumbar spine, which nerve root in particular is affected, with, in this case, with those symptoms. What I have here is a picture of a common test that's done at the bedside called the straight leg test or straight leg raise test. And this is to assess if there's compression of the nerves in the lumbar spine. It doesn't tell you exactly which nerves are affected, but it can tell you that there's some kind of compression going on. And this is something that I do very routinely in the office. Primary care does this as well to see if there's any nerve compression there. And usually the workup for sciatica also includes some kind of imaging. And so I've put a few imaging modalities on the right side of the screen here. The first picture is an X-ray. This is of the lumbar spine. And what you can see here is some of the bones. You can imagine that the discs are in between. The difficulty is that you can't see a whole lot else about, whether or not the spinal cord itself is being affected by any degeneration or any issues with the disc here. Really, the best image to assess for that is an MRI, which is what I have here on the right side in these two images. You can see that you can almost be a little bit fooled by the image here, where you might say, this, I can't really tell if this disc is protruding or not into the spinal cord. But then when you look here at the MRI, here as well, a little bit further up, you can see that this disc is actually pushing a little bit on the spinal cord in the back here. And so the MRI is usually the best image to assess for whether or not there is protrusion of the disc and if it's causing, if it's impinging on the spinal cord. Sometimes folks can have protrusions of the disc that is seen on MRI, and maybe at an MRI for a different reason. Maybe you're a part of a clinical trial or some kind of study, and they had to get an MRI of your lower back. And folks can have some protrusion of the disc, and they may have no symptoms. And so it really, you have to pair the presentation, the history, the symptoms with the diagnostic test. And so it's, some folks may just have a little bit of protrusion here, but it really depends, are you having symptoms from it? And that is where, seeking medical advice from your primary care doctor or a neurologist is really of the utmost importance. So let's talk briefly a little bit about some of the treatment modalities. And I like to think of these as kind of three buckets of treatment when we're thinking about sciatica. The first one is physical therapy. And I think in most cases, unless there is an indication for more emergent treatment, most primary care doctors, neurologists, surgeons would recommend some trial of physical therapy. And it's because the research shows us that physical therapy done within the first 2 weeks to 3 months of symptoms has been shown to decrease back pain, decrease leg pain, and decrease disability over the ensuing year that folks were studied in this particular trial. And so most folks would recommend some type of physical therapy initially before thinking about other kind of modalities. But that being said, sciatica is painful and it can be very disabling. And so it is also kind of paired with usually some kind of medication to help reduce the pain that folks may be having. And then we'll talk a little bit about procedures, whether those are injections or surgery as another treatment modality. But I generally think of this as, how can I get someone, if they don't have an indication for surgery, how can I get them to do some physical therapy? How can I help alleviate their pain with some medications? The asterisk that I'll put kind of as we talk about treatment is that, generally speaking, for at least 70% of patients, upwards or closer to 90% of patients, sciatica is generally self-limiting and will resolve within 3 months. And that is, with conservative management, no procedures or surgeries in those, in that case. And so that's a little bit of a caveat. That being said, I think it's still worthwhile when someone's coming in with severe symptoms, weakness, all of that, that we do our best to help treat. And so let's talk a little bit about medications. Some of these may not be particularly new to folks on the call, but we usually use nerve or neuropathic pain medications. And the go-to, the standard of care, as recommended, is by the Academy of Neurology, is gabapentin or pregabalin. The brand names for gabapentin is Neurontin, and the brand name for pregabalin is Lyrica. These are medications that are usually dosed about 3 times a day. And the studies tell us that they're both effective for neuropathic pain and sciatica. But generally speaking, gabapentin tends to have less side effects. The most common side effect with gabapentin is drowsiness, sleepiness. Whereas pregabalin has that as a side effect, but also some folks have reported more GI, kind of nausea, vomiting, kind of stomach upset. And those are kind of a little bit more, severe in the case of pregabalin. And so generally gabapentin is the go-to that most folks will start with. And you can slowly titrate, increase the dose of gabapentin over time to get the effect that you want. Another medication is Cymbalta duloxetine. This medication is a SSRI, or a selective serotonin reuptake inhibitor. It can be used to treat depression and anxiety, but at smaller doses, it can also be useful in treating neuropathic pain. And so some physicians will also prescribe Cymbalta duloxetine. Other treatment modalities, kind of medication-wise, include steroids, oral steroids, and also epidural steroid injections, which we'll get to. And then I think kind of as a part of the holistic kind of wraparound kind of multimodal pain control, I think using NSAIDs or ibuprofen, um, Tylenol, Motrin, um, paired with muscle relaxers can be helpful in treating the pain associated with sciatica. And lastly, I'll just mention that in these cases, we tend to avoid opioids, namely because they have even worse sedating or somnolence-inducing effects than gabapentin. And it generally doesn't improve outcomes. If anything, it actually makes outcomes worse. If you're more somnolent, you're more likely to fall, or you're more likely to get hurt. And so we generally avoid opioids in this case. This is my only kind of very technical looking slide for the entire presentation, but I want to include it here because there's been discussion and talk of whether or not getting steroids, oral steroids like prednisone, can improve outcomes in patients that have sciatica, particularly from that disc protrusion that I mentioned. And so just to orient everyone to what's being shown here, here I have this was a study of patients who came in within about 2 weeks to 3 months of symptoms. They had confirmed sciatica on their MRIs, and they were given a 2-week trial of prednisone by mouth daily. And they were compared, their outcomes, their disability and pain scales were compared to folks who did not receive prednisone or the oral steroid over that period of time. Those folks, were given, the usual kind of things that we would give folks, whether it's gabapentin or Lyrica. And so up here we have the disability index. This is a very common used index of disability in these studies, and there is there's some improvement in disability with oral prednisone at maybe about the 3-week mark, and then some benefit as well about a year out. This is the time in weeks. And so there's some benefit, although the study does note that it is fairly marginal to getting prednisone within the first 3 months of symptoms, and the effect could last up to a year. That being said, there's a good amount of speculation as to whether or not, is it truly the prednisone that is leading to this effect, or is there something about this population of folks who got the prednisone that, makes it more likely that they are noting some improvement over time. And then lastly, down here, this is a pain scale, same kind of timeline, 0 weeks to 52 weeks. And there is no significant difference in reported pain that patients experience over that year, regardless of if they received prednisone or placebo. So generally speaking, kind of taking this all together, I think the data suggests that there is some role for steroids, but it doesn't seem to have a significant enough effect to justify giving every patient that you have a suspicion for sciatica steroids. I've seen some surgeons who are going to operate give a small amount of prednisone to help reduce some of the inflammation right before surgery. But it is not commonplace within practice for folks to give oral steroids in the case of sciatica. The data doesn't seem to be convincing enough. And the last kind of modality when we're talking about treatment for sciatica is procedures. And the procedures can take multiple different forms. Steroid injections, usually some kind of cortisol or cortisone kind of steroid injections. These are usually done by pain specialists. These are folks who have pain fellowship training, and they usually are either neurologists, physical medicine and rehabilitation doctors, or PM&R doctors, or anesthesiologists who perform these injections. The decision on whether or not to pursue injections is one that is best had with the folks or the person who would theoretically be giving the injection. There's a good amount, there are some side effects obviously associated with having a procedure, and there are benefits as well. Um, Steroid injections seem to have their most benefit on pain and disability if done within the first 2 weeks of symptom onset. And so it's worth a discussion with the physician about whether or not it's the best option to pursue steroids, and kind of what would be the ultimate goal of getting an injection. And then lastly, surgery, or spinal cord stimulator placement, which is kind of a little bit of a newer option. Um, I'll try not to speak outside of my specialty. This is something that is under the realm of neurosurgery, or orthopedic spine surgeons, are the ones who do these procedures. And so um, I would recommend, if surgery is a consideration, that's best to consult with those specialists, because there are particularities about how the MRI appears, how the symptoms are, that are a little bit beyond my expertise in terms of when is the right time to pursue surgery. But certainly, it is worth, if it is a consideration, it's worth consulting with these particular folks, neurosurgery, orthopedic spine surgery, for additional guidance.
Dr. Daly, this is Dr. Daly. This is Dr. Parker. You said that the sciatica is generally self-limited, and then we started talking about different ways to treat it. And some people have, I guess, it's chronic sciatica, and they think they're disabled. So I'm trying to figure out, at what point do we stop saying sciatica is chronic and doesn't require any intervention other than physical therapy, versus this is, life-changing, it's a chronic disability, and I need surgery, I need this, and I need that?
Yeah, no, that's a great question. And so the guidelines say that sciatica that has been going on for greater than 3 months, some suggest 6 months, and has been not responsive to physical therapy, and other kind of more conservative measures, that is kind of when we call it chronic sciatica. And in those cases of chronic sciatica, that's when we're talking more about the use of injections, the use of stimulators, or surgery, because in those cases, there's our conservative measures, right, have not worked. And so that is when we're talking with our neurosurgery colleagues, our ortho spine folks, about how do we improve functionality, how do we help with pain. And so yeah, that's usually the cutoff of kind of when we start thinking about chronic sciatica. And at that point, we're kind of in a different ball game. We're going beyond just the use of Neurontin or Lyrica to try and help. Did that answer your question, Dr. Parker?
Yes, it does. Yes, that answers my question. Thank you. There was one other question that was referred. You talked about, if you wouldn't mind, I'm sorry I missed some of the discussion, the earlier discussion, but like when you have sciatic pain, can you describe where it is? People say, well, what's the pain that I have if it goes down the side of my leg? Can you tell them really where the pain should be if you truly have something like sciatica?
Yeah, that's a great question. And definitely, so the pain from sciatica generally goes down the back of the leg. It starts we'll start in the lower back, goes down the back of the leg, can often include kind of the butt region as well. And it will be the back of the leg, and also sometimes the outside of the leg, going down, usually past the knee, going down towards, down the calf in the back, and down towards the bottom of the foot. That's, kind of the classic kind of characteristic type of location for sciatica pain. And the pain is kind of this almost a pins and needles kind of sharp. Some folks describe kind of electric kind of feeling to the pain. And it, sometimes has its ebbs and flows where it might come and go, or it might kind of be there pretty consistently and have these moments where it kind of gets worse and kind of calms down.
Okay. Are there other signs and symptoms of sciatica and anything we can do to prevent it?
Yes, I'm getting to that in just a sec. So hang with me.
Okay.
Awesome, awesome, awesome. So the last bit that I'll get on before I get to the worrying signs and kind of the prevention is things that kind of sound like sciatica and can present very similarly to it, that are not from the impingement of the nerve or irritation or a protrusion of the disc in the spinal cord. And this is something called piriformis syndrome. This muscle here, called the piriformis muscle, can sometimes entrap the sciatic nerve, and it can cause pain that is usually most maximal in kind of the glute kind of region and will extend down. But notably, this generally does not go past the knee. And so this is kind of where the distinction between, sciatica from an issue in the root of the nerve near the spine and irritation of the sciatic nerve from this piriformis muscle, kind of entrapping the nerve. It's important to distinguish that. And that's something that I try to distinguish when I'm seeing folks in the clinic. And then two other things that can sometimes, that I commonly ask folks when I see them in the clinic is, well, do you have a wallet that you sit on all the time? And is your wallet on the same side that you have your pain? This has been called quote unquote wallet neuritis, but it's basically from irritation of the nerves in the pelvic region from, your wallet, your massive wallet kind of pushing on your lower back and causing it to be in misalignment. Or if you do yoga and you're sitting in this kind of lotus pose for long periods of time, you can also irritate the nerve in the back that way. So before we get to questions, I'll just include a few worrying signs. The things to worry about are if you are having, acute onset or really worsening weakness and or numbness within that region, the back part of the leg going down to the foot. If you're having trouble picking up your foot because of weakness, that is when you want to see, either go to an urgent care or get an appointment to see your doctor quite soon. If you're having new bowel or bladder issues, issues going to the bathroom, not going to the bathroom as regularly as you normally do, this is when you'd want to see. I think in this case, I would say you should go to an urgent care and kind of skip getting your nearest appointment with your primary care doctor. Lack of sensation in kind of the perianal region, kind of the area where you sit, would also, prompt going to an urgent care or seeing your doctor soon. And lastly, if symptoms are going on for longer than 3 months, kind of getting into this chronic kind of sciatica distinction. And lastly, prevention, right? And this is some of the things that folks have, you guys got a good intro to this earlier on on the Zoom, but appropriate exercise, good lifting technique in particular. I've seen folks who, were, lifting a heavy weight and, their technique wasn't the best, or they moved up their weight too much and they, might have slipped a disc. Good posture when we're sitting, when we're, walking around, having appropriate footwear. All these things are important to keep the lower spine in alignment, and prevent that kind of degeneration that can happen over time. And lastly, good stretching, whether it's before or after activity, with things like yoga or Tai Chi, or even just, regular static stretches. Those are all helpful in preventing that wear and tear on the lumbar spine.